Logged in onto the seminar. All the consultants and from the Ramakrishna Hospital and from outside hospital from the city of Coimbatore, and all the doctors from our hospital and from the city. Again, good evening to all. And we have been conducting for the last 2 years a series of webinar every month, last Saturday. And this month, our speakers are Dr. S. Tyagaraja, FRCS cardiothoracic surgery, and he is a senior cardiac surgeon, and he is one of the pioneers in minimally invasive cardiac surgery, and probably he has the maximum number of minimally invasive surgeries for valve replacements in South India. And probably because of him, our hospital has become one of the final destinations for minimally invasive valve surgeries for many patients. And many patients from the southern India, they come to our hospital for the minimally invasive surgeries. And he is going to talk about minimally invasive valve replacements, a leading destination in Tamil Nadu. And the other speaker is Dr. Vikram Vignesh, the consultant cardiologist and electrophysiologist. And he is going to talk about the commonest arrhythmias, supraventricular tachyarrhythmias, how to manage. And I think it will be useful for all the specialists and also general practitioners. So when to interfere and all those details, I think I am also eager to hear to his lecture, and he is going to talk about that aspect. And I welcome both the speakers, and I thank them for accepting our invitation and taking part in this webinar. And now I would like to call upon Dr. Tyagaraja for taking over. Dr. Tyagaraja, please.
Good afternoon, everybody. I'm sorry, my voice is a bit strained.
But you can slightly increase your volume, I think.
Yeah. Okay. So now Ramakrishna Hospital has become the leading destination for mixed surgeries in Tamil Nadu. So what is mixed? Minimally invasive cardiac surgery is the one that avoids division of full sternum. Mixed surgeries have been reported since 1990s, but due to various technical difficulties, it was not adopted widely. But in the late 1990s, port access surgery was introduced and tried worldwide. But it failed because of endoaortic balloon complications. Now, recently, minimally invasive cardiac surgery has undergone a dramatic change because of the introduction of chitwood clamp, and this revolutionized mixed surgery. Recently, robotic surgery is also introduced in isolated center with very limited results. Currently, mixed surgeries are performed in direct vision with long mono-shafted instruments. So these are all the incisions that are possible. We have upper J sternotomy, right anterior thoracotomy, inverted T thoracotomy, right parasternal thoracotomy. These are all incisions used for doing minimally invasive aortic valve replacements. Several other incisions have been tried, and these are all things that are seen in the literature. Thoracotomy, right anterior thoracotomy, second to fourth space anywhere they have opened, left lateral thoracotomy, left posterior thoracotomy, right vertical infraaxillary thoracotomy, etc. There are also partial sternotomies. Almost all the alphabets have been tried. T, J, L, V, all sorts of incisions have been tried. Port access surgery failed. But now robotic assisted surgery is slowly coming up. But in cardiac surgery, it is not come into full-fledged use. Whereas in laparoscopic surgery and pelvic surgery, robotic surgery has been used. So mixed approaches, as I said, many approaches have been tried historically. Now the common ones are upper mini sternotomy and right anterior thoracotomy are popular and widely used. Recently, we have also done transactionary AVR, and that is reported only in few centers worldwide. We have done so far 3 cases. Method. We routinely use transesophageal echocardiogram. Anesthetist should be fully trained for a TOE. Femoral cannulation should be done via routinely. We also use centrifugal pump and vacuum assisted drainage. This is a small incision that done in the upper partial sternotomy. The aorta is open and you can see the sizer going in. This is sizing of the valve. So in the next video, you will see the valve has been in place and the valve is checked, and all through the small incision. That's a mechanical valve that's being put in.
Valve opening closure.
So minimal invasive AVR, we have done so far about 80 cases. Now this is the male-female distribution. And this is the tissue versus mechanical valve. And we have done the age distribution of the tissue versus mechanical. You can see that as and when the older age group, we are putting more tissue valves, and the younger group, we are putting mechanical valves. So this is the end result. You have a very small incision in the upper part of the sternum, and through which the aortic valve is replaced. So we're coming to minimal invasive mitral valve replacement. We routinely use transesophageal femoral cannulation and also transesophageal echo. Separate SVC cannula is used. We do it to the right fourth space thoracotomy. Special retractors are used for left atrial retraction. We use what's called a core gate retractor, and a soft tissue retractor is used. We use centrifugal pump, vacuum assisted drainage. These are all the incisions through which the mitral valve has been replaced. Right sided, below the nipple, very small incision. Some more examples of small incisions done through the right chest. So total number, we have done about 120 cases, male-female distribution. This is once again the male-female distribution shown in the age group distribution. Mechanical versus tissue. The older age group gets a tissue valve. The younger age group, we put mechanical valves. So far, the complications that we've seen are bleeding reopening in 2% of the cases, stroke risk in 0.5%, limb-related complications 0%, paravalvular leak 0%, infective endocarditis 0%, pacemaker 0% after mix, LV rupture 0.5%, and mortality is 1%. So that is an LV rupture patient. One of the post-operative patients, the next day morning after the surgery, there was sudden collapse. Once we re-explored, we found that there was LV rupture. So these are all the special instruments that are used. Long monoshafted instruments on this side. And we have the stick-wood clamp. And this is a flexible clamp. This is an example of a transaxillary aortic valve replacement. You can see a smaller, where the incision is made. The arm is extended. Vertical incision on the anterior axillary line is made. And the chest is open and a soft tissue retractor is used. Once again, the same instruments are used: chitwood clamp, long monoshafted instruments, flexible clamp. So in transaxillary area, the Italians have presented many papers from this only one group in Ancona, and they discussed about whether this is about the future of the aortic surgery. Therefore, the maximum number is done by Japanese, and this one center specializes in transaxillary aortic valve replacement. If you see that the incision, the aorta, you can see the valve is directly in view, almost in the plane of the mitral valve. You can see the valve already inserted here. How did we come into this transaxillary aortic valve replacement? We have a long-term experience with mixed AVR, and the common approach is via partial sternotomy. In some cases, we found it very difficult because in whom the aorta is enlarged or pushed to the right, the heart is pushed to the left. In those cases, mixed AVR via sternotomy is very difficult. Sometimes we also had issues where we had to convert to a full sternotomy. we routinely do minimally invasive mitral valve replacement. But while doing pulse string for cardioplegia, in cases in which there is unfolding of the aorta will be very close to the thoracotomy incision and dilated, but mitral valve will be difficult in those cases. So we saw this interesting presentation by Italian group. Then we started selecting patients for the transactionary AVR. So this is a routine chest X-ray. In this, you can see the aorta is unfolded, pushed to the right, heart is pushed down to the left. So in those cases, approaching the aorta through the right thoracotomy incision transactionary is very easy. So this is CT scan done preoperatively, and anything less than 15 centimeter, we can do the valve replacement through the transactionary route. So the patient is positioned with right arm elevated, right lateral aspect chest elevated, fourth or third space entered, just lateral to the anterior axillary, extending 5 to 6 centimeter. There's no cartilage dislocation. This approach improves the exposure to the entire aorta actually. So once again, femoral cannulation, TOE assessment, pericardial stay, cardioplegia by aortic route, LV vent by right superior pulmonary vein. The normal aortic clamp is sometimes used. We use routinely chit-root clamp and a singlet clamp with Iotic. So selection criteria is when the aorta is more to the right side, enlargement of the aorta, distance from the chest wall to aortic wall less than 15 centimeter, heart is pushed to the horizontal position. The Japanese have described what's called a stone age technique, where multiple sutures are made on the pericardium and the whole heart is retracted towards the incision. So these are random stitches. So that is why it is called a stone age technique. So another picture to show the valve, native valve, deceased valve, and this is a valve, tissue valve is replaced. So you can see how close the aorta is to the chest wall, and we are suturing the aorta after the operation. So this is the aorta after closure being done. So we use the knot pusher on all cases because the valve is deeper. So the knot pusher helps us in tying the valve. So these are the end results. You can see the very small incision made, chest X-ray showing the valve inside, and this is day 4. Patient is having good recovery. So this is another lady, obese lady, but still the X-ray showed the aorta was unfolded. So we decided to do it through the transactionary route. So this lady had a successful AVR. See how close the aorta is to the chest wall. So very small incision. So the advantages, isolated valve replacement can be done by minimally invasive methods comfortably. Transactionary AVR offers durable valve replacement options to selected low and high risk patients. Minimal scar and pain, early discharge, better long-term results. Thank you.
Thank you,
Thank
Dr.
you, sir.
Pyarajamurthy, and probably we'll have the question sessions later.
Okay, sure.
And now I'd like to call upon Dr. Vikram Vignesh. Vikram?
Good evening, everyone, sir.
Yeah.
I thank our dean and our hospital administration for this opportunity. So, for the next 20 minutes, I'll be discussing on the management of supraventricular tachycardia from electrophysiological perspective. So, when we get an ECG of a patient who has tachycardia, the first thing we look at is what is the width of the QRS. When the width of the QRS is less than 120 millisecond, we label tachycardia as narrow QRS complex tachycardia. The next thing that one should be looking after confirming the narrow QRS tachycardia is the position of the P wave in the RR interval. What do I mean by this? So this is an example of a tachycardia. You can see the heart rate is less than more than 100.
Is the screen visible?
Is my screen visible, sir?
Yes, yes.
Sir. Okay.
Yeah. So how to identify this? So this is a tachycardia because heart rate is more than 100. And if you look at the QRS, the width of the QRS is less than 120 millisecond. So once we confirm this, then we count the number of P's and we count the number of R or QRS complexes. When number of P is equal to number of QRS complexes, the next step is to see the distance of the R wave from the previous QRS to the next P wave. I mean, not the one that is related to this. So if you take the R wave of this QRS complex, we move to the next P of the next beat and we see the distance between this R wave and this P wave. So this we call it as RP interval. When this RP interval is more than half of the RR interval or more than 50% of this RR interval, we call it as long RP tachycardia. On the contrary, when the distance between the R wave and the P wave is less than this half or this blue line, we call it as short RP tachycardia. So this is the brief overview of the algorithm approach of the narrow QRS complex tachycardia. So we see it whether it's regular or irregular. If it is irregular, the differential diagnosis are very less. It can be atrial fibrillation or a flutter or a multifocal atrial tachycardia or just an atrial tachycardia. Commonly, what we see here as supraventricular tachycardia is the regular RR interval tachycardia. So here we see the number of P and number of QRSs. If both have a 1:1 ratio, then we measure the R to P interval. If the R to P interval is less than 50% of the RR interval, we have the two common differential diagnoses, that is AV-NRT, and the second common is AV-RT. If the RR interval is long, then we call it as long RP tachycardia, and commonest differential diagnosis here is atrial tachycardia and atypical AV-NRT. So here is it's an animation that you can see. So we will concentrate on AV nodal reentrant tachycardia, that is AV-NRT. The second common tachycardia is AV-RT, that is atrioventricular reentrant tachycardia, and the third common one is atrial tachycardia. So what are the difference between these three? If you closely observe this animation, so for every tachycardia to sustain, what you need is a circuit. So a circuit is nothing but like a cycle or a closed wheel. If you look at the AV nodal reentrant tachycardia, the entire circuit is present in the AV node. As you know, the AV node is a central or a midline structure. So both this atria and ventricle gets activated simultaneously. So here is the circuit, it goes up and it comes down at the same time. So what is the resulting consequence of this is both P and QRS, that is atrial activity and the ventricular activity, will occur at the same time. So that is what is AV nodal reentrant tachycardia. Coming to the second common tachycardia, that is AV reentrant tachycardia, that's AV-RT. So what happens here is, this is what we often talk about as Wpw, or that is Wolff-Parkinson-White syndrome. Here what happens is, apart from the regular connection of sinus node, AV node, His-Purkinje system, there is an accessory pathway which we call it as bundle of Kent. Because of this bundle of Kent, what really happens is The sinus impulse that comes like this through the normal His-Purkinje system, it can conduct in a reverse direction through this bundle of Kent and completes a circle. What is the difference between this and this is, here it takes some time for this AV node to conduct down through the His-Purkinje system, and from here muscle to muscle connection followed by bundle of Kent connection. So the atria and ventricle are not activated simultaneously, rather ventricle gets activated followed by the atrium. So the distance between the R and the P is little longer when you compare to the classical AV nodal reentrant tachycardia. So the third common tachycardia is an atrial tachycardia. Here you see only the singular word atrial is there. That means it is neither it is not dependent on ventricle, nor it has any accessory pathway. So the small circuit, it is entirely present in the atrium, unlike the other two tachycardias which requires two chambers for sustenance. So this is atrial tachycardia, and it can independently occur in spite of the ventricular activity. So we will see how to differentiate and identify and treat based on the electrocardiogram. So first is the AV nodal reentrant tachycardia, as I reiterate again. So the circuit is central and both the atria and the ventricle act simultaneously. So what really happens because of this simultaneous activation is, you won't be able to really identify a separate P. The reason is the P gets buried inside the QRS. When we give this QRS complex to anyone, unless one looks very carefully, they will say this is a normal QRS complex without a P wave. But if you closely observe, you can see a notch or a buffalo hump-like appearance at the end of the QRS, and this is what is the P wave that is appearing like a notch here. So if suppose if we give this ECG, how to go by the algorithmic approach in this. So is this a regular tachycardia? Yes, RR interval looks fairly regular. The QRS is less than 120 milliseconds. So this is a supraventricular tachycardia. I told the important step is to identify the relation between the R of the previous beat and the P of the next beat. But if you look here, you're really not able to observe any P wave here. What you see here is only a T wave. But on close observation in the lead 2, what we see here is, at the end of the QRS, you see a small nibble like a downstroke that has happened, and this is what is called as P or a pseudo P. So when we see the pseudo P, or other thing that you can do is observing the lead V1, and I am blowing up this image of lead V1 alone, and what you see here is at the end of a QRS, again you see a positively notched wave. This we call it as pseudo R wave. These are the manifestations of the P wave which produces this kind of a pseudo S and a pseudo R pattern. So for you to appreciate, so my cursor is hovering over the tachycardia, which is an AV NRT, where you can see a QRS followed by a upstroke notch, which is a pseudo R. The same patient in the sinus rhythm do not have any such upstroke at the end of the QRS. So what you're actually seeing here is the P wave that is falling on the QRS complex. So when you do not see any visible P wave, the tachycardia is likely to be AV-NRT when it is regular and narrow complex. So next we will come to the Wpw syndrome, or the Wolff-Parkinson-White syndrome, due to the presence of an accessory pathway or the Kent pathway. So what really happens? So some individuals are born with this extra connection or the extra wire or an accessory pathway. So what happens in that individual is the ventricle is getting activated both by the normal His-Purkinje system and also by the pathway. Because the pathway conduction is little faster, in ECG you observe a short PR interval and a slurred upstroke, which we call it as delta wave. So this we call it as Wpw pattern. How does it become a syndrome? When this patient develops recurrent palpitations, then we call it as Wpw syndrome. And how do these patients get palpitations? So sometimes what will happen is, whenever there is an extra heartbeat, extra beat originating from the atrium, the pathway will get blocked. So the extra atrial ectopic beat will conduct down in the ventricle through the normal His-Purkinje system, and it slowly ascends up. At this time, the pathway would have recovered, so it conducts back. So this forms an on and on, this activity goes, and what occurs, it is called as orthodromic AVRT, or we can call it as simply AVRT. If you recollect earlier, I told the R wave won't, the P wave won't be very close to the QRS complex, but still because of the pathway property, the RR interval and RP interval, the RP interval will be less than 50%, but not as close as an AV NRT. So again, I have put an ECG. So this is a regular narrow complex tachycardia, which is a supraventricular tachycardia. So again, we go to the important process of searching for the P wave. So whenever you search for the P wave, one important property of the T wave that you should know is T wave is always a smooth wave. Okay, whenever you see a notch in a T wave, that is likely to be a P wave that is disturbing the T wave. So if you blow up this lead V1, what you observe here is a small nibble. So this is likely to be the P wave. And if you look, when you measure R to P, it is not crossing more than half of the RR interval. So it is a short RP tachycardia, but it is not as close as an AVNRT. So this tachycardia is likely to be AVRT or an orthodromic AVRT. So coming to the third tachycardia, before that I would like to impress upon how a normal P wave is generated. So if you look at lead V1 or lead 2, we will know how a normal P wave is generated. You know the sinus node is in the right atrium. So the P waves, the activation wavefront comes like this and goes to the left atrium. Because of this normal activation, you see positive P waves in majority of the leads, except lead V1. So when you do not see this normal morphology of positive P wave in lead 1 or lead 2, you should suspect the P waves are not originating from the normal sinus node, rather it is coming from a different area. When this occurs in a very fast, I mean when the PP interval is more than 100, we call it as atrial tachycardia or the ectopic atrial tachycardia. So I put an example here. So this is a lead 2. So I have put the first beat is a sinus rhythm beat. So what you see here is a normal appearing positive P wave followed by QRS. So let us go to the tachycardia beat in the left side of the panel. If you look at this QRS and the next P, it is more than half of the RR interval. But if you closely observe the morphology of the P, you see a very altered morphology of the P when compared to the sinus impulse. That means it is arising from different area of the atrium. So we label this tachycardia as atrial tachycardia. So I have given you an example here, and again it will be difficult for you to see in the screen. So I have blown up just the lead 3 alone. If you look at the lead 3, you can see the P wave. This is not a T wave because I said the T waves are commonly smooth appearing waves. So if you look at these P waves, it occurs in a very notched pattern, and it is exactly sitting in the middle. You do not know whether it's short RP or long RP, but I would like you to see closely the morphology. You see that it goes positive, then becomes negative. Whenever it has this morphology, that means it is originating from some other place in the atrium. So this is likely to be an ectopic atrial tachycardia. So this is how we differentiate the regular tachycardia into long RP and a short RP tachycardia. So what do we do in emergency? How do we treat? So whenever these patients come to the emergency, when they are hemodynamically stable, we do Valsalva maneuver. We give commonly injection adenosine 6 to 12 milligram. Remember, whenever you give adenosine, it can be both diagnostic and therapeutic. Meaning, if your tachycardia is, even if it is not terminating, the adenosine will act at the level of AV node and will help you to find the diagnosis of the patient. and it can be therapeutic because it commonly terminates AVNRT, it commonly terminates AVRT. So when the patient comes with the palpitations, breathlessness, pre-syncope symptoms, just a single dose of adenosine can terminate that episode, though it cannot prevent the recurrence. So I have put an example that we came across. So if this rhythm strip is a regular narrow QRS tachycardia, but you are not really sure what is the diagnosis because you do not see any P waves, or there really any P waves, we were not sure. So what we did was we gave injection adenosine. So what you observe is after we gave injection adenosine, the adenosine kind of blocked the AV node. You see one QRS complex here, you see another QRS complex here, but what is the between two QRS complex, what is really happening is you see a very sawtooth appearing waves. These are called as flutter waves. Why there is no gap between two waves? I'll show you the circuit, because the flutter waves are sawtooth waves, because here there is this entire circuit is in the atrium and it continuously activates like a circle. So what you get is a sawtooth wave. So how do we manage these supraventricular tachycardia patients? So according to this European Society of Cardiology guidelines, when they come to the emergency or to your clinic, just check their blood pressure. If they are hemodynamically stable, then we do Valsalva maneuver. If the Valsalva maneuver is ineffective, then we go to the injection adenosine. After trying at least 12 milligram of adenosine, even if the tachycardia persists, then you can give intravenous verapamil or diltiazem, or as a third option, you can give a intravenous beta blocker, SML or beta blocker, beta lock or anything. When the patient is coming with low blood pressure, you can directly go and give synchronized cardioversion to this patient. This is acute management of the patients in the ER. So, but how do we chronically manage this patient? How do we prevent recurrence? Because in a WPW, the pathway is going, the Kent pathway is going to be persistent. They're going to get recurrent tachycardia. Even in an AV NRT, the slow pathway and the fast pathway, which gives rise to these tachycardia, are also going to be present all the time, and they have always tendency for recurrence. So how do we manage these patients? So one thing we can do is we can always try drug therapy for these patients. We can give calcium channel blockers or beta blockers. Mind you, they have their own adverse effects themselves. And there is always a chance for recurrence when we put these patients on drug. At least 20 to 40% of these patients have the tachycardia recurrence. So what do we offer the permanent cure, or what is the next best solution for these patients? I would like to to introduce what is called as electrophysiological study with radiofrequency ablation. So what is the concept behind this electrophysiological study and radiofrequency ablation? So this is an electrophysiological lab set up in Sri Ramakrishna Hospital cath lab. So what we basically do is we study the signals that are present inside the heart, that is SA node, AV node, and his Purkinje system. And how do we do this? We do not do any major surgical procedure. Like an angiogram, we do this by interventional techniques, that is through the right femoral venous approach. So once we access the chambers of the heart through the right femoral venous approach, that is through the groin area, we place these catheters inside the heart. So when we place these catheters inside the heart, we study what is called as electrocardiogram. A ECG is nothing but studying the signals of the heart from outside by placing the electrodes, one in the right hand, one in the left hand and the left foot. But here we place the closely spaced catheters inside the cardiac chamber by non-surgical means. When we study these signals, I'll show you. This is one of our patients where we have placed multiple catheters inside the heart. And mind you, these procedures are not done under general anesthesia or anything. These are done with the local anesthesia at the groin site with conscious sedation. So when we place these multiple catheters, we will be able to localize where the abnormal circuitry of the tachycardia is present. So once we localize the abnormal circuitry of the heart, then we do what is called as radiofrequency ablation. The radiofrequency ablation is nothing but a form of a heat energy like a laser, which is completely safe and the patient won't be feeling pain. So once we apply this radiofrequency waves to the tachycardia circuit, the tachycardia circuit gets ablated in the local site, and it offers a permanent solution from the recurrence of the tachycardia. So this is the over thousands and thousands of patients. It's a meta-analysis of a large number of patients who had undergone a EPS plus electrophysiological study plus RFE. If you look at the percentage of the cure, if you take AVNRT, which is the most common tachycardia, the acute success rate is 97%, and over a period of 30 years, the recurrent rate is 2%. If you come to the next common tachycardia, that is Wpw Syndrome AVRT, the success rate is 92% and the recurrence rate is 8% over a period of 20 to 30 years. And if you look at CTI dependent atrial flutter and atrial tachycardia also, they have a high rate of success. So, ladies and gentlemen, to conclude, a systematic approach to narrow QRS tachycardia ECG will help in the differential diagnosis. When you encounter such a patients in an ER or in a clinic, you do vagal maneuvers and give adenosine. Remember, adenosine can be both diagnostic and therapeutic. So simple thing that you have to do is when you attach the defib monitor, please run the strip down when you give adenosine, so that it helps you in differential diagnosis and know the mechanism of termination. Always document a proper 12-lead ECG, because that helps in a long way to diagnose and treat the patients further. And finally, electrophysiological study and radiofrequency ablation is a definitive cure for majority of the supraventricular tachycardia that we commonly encounter in the clinical practice. I thank you one and all for the patience listening. Thank you.
Dr. Vikram, it was an interesting lecture.
Thank you, sir.
So informative, and I think everybody for everybody that would have been useful. And any questions to Dr. Thyaraj and Dr. Vikram Dinesh? So, Dr. Durekanan, sir. Good evening, sir. He's a pediatrician and retired joint director of health services, Coimbatore. Welcome to the webinar, sir.
So good evening, Balaji here. I have a question.
Yes, sir.
What is the role of mix for CABG,
Yeah.
case selection, and can
In
you?
minimally invasive, so we at Ramakrishna Hospital are doing single vessel grafting hemato-LED. Multi-vessel we are not doing it because there are some issues with grafting and it takes a long time, and in many times we have to put the patient on a pump. We do most of the cases off pump, which is the least invasive method. But if you want to do only for smaller incision, then if I have to go on a pump, then conceptually it begins a clash. So which philosophy are you following? If I want to put the patient on the pump and just to achieve a smaller incision, if I want to do the operation, then it is not minimally invasive, it is maximally invasive, physiologically. Anatomically, it is minimally invasive. So we decided to do it off pump sternotomy for multivessel.
Thank you. Question to Vikram.
Yes, sir.
When you take up patients for RF ablation, is there any age criteria, like very young patients or very old patients?
Sir,
Sometimes they say the pathway burns out in young patients. So do you use any age criteria?
Sir, we mostly use the weight criteria, sir. The weight criteria we use because the ablation catheters that we use are usually made for the adults. So if the person is more than 20 kg, if the patient is more than 20 kg, we go and take up the patient who are having recurrent symptoms. But if a pediatric age group, if the patient is having recurrent symptoms and the symptoms are of malignant in nature, that is, it's leading to heart failure because of recurrent tachycardia or syncope, or the patient is not going to school because of the recurrent or daily onset of symptoms in spite of drugs, then we do for those patients also. But at least we expect a weight of 20 kg for our patients.
Thank you.
Thank you, sir.
Thank you, Balaji. Any other questions or opinions?
Good evening, sir.
Good evening, sir. This is Dr. Vijay. I will have a question for Dr. Vikram.
Good evening, sir.
In Epstein's, is there a role for prophylactically identifying the accessory pathway, or we'll proceed only if there is if the patient has arrhythmia?
Sir, if the patient is having arrhythmia, then electrophysiological study is indicated. But if you are
Okay.
taking the patient for a corrective surgery, you
Okay.
can identify the pathway during the surgery and you can ablate or do a surgical resection of that pathway. Otherwise, we don't do any routine electrophysiological study for a patient if they do not have any symptom in an Epstein's.
Okay. Okay. The reason I asked you is there are many Epstein's, a milder form of Epstein's who don't have symptoms. They might even have a moderate to severe tricuspid regurgitation, but they are asymptomatic. So in such patients, we don't need to do prophylactic EP studies.
Yes. So if those patients are working in a high risk occupation where even a palpitation and syncope will threaten their life. Example, we always give an example of pilots. Even if they have asymptomatic Wpw, we go and ablate. But one easier method is do a treadmill test, and if the pathway is conducting till the stage 4 or when the heart rate is reaching more than 200, then we have a reason to prophylactically ablate pathways. Otherwise, no. Sir.
Oh. Oh.
Thank you, sir.
Okay. Thank you, sir. Thank you.
If there are no other questions, then I thank Dr. Tyagaraja and Dr. Vikram Vignesh for taking part in this webinar, sparing their time. And on behalf of the management, I thank both of them. And I thank all the consultants, doctors from Ramakrishna Hospital and from Coimbatore for taking part in this webinar. Thank you so much. Thank you once again.
Thank you, sir. Thank you very
Thank
much.
you for the opportunity.
I think I got infected from Tyagaraja, I think. Sir, Durakanan, sir. See you, sir. Your mic is off, sir.